Welcome to episode 10 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. In today's episode, Dr. Oliver Thomson joins us. Oliver practices as an osteopath in London, UK, where he works in a multidisciplinary clinic with a particular focus on the treatment and management of back pain and sciatica. He completed his PhD in osteopathy at the University of Brighton, where he explored osteopaths' clinical reasoning, and he has published extensively in this area. In addition to his clinical role, he also works as an associate professor at the University College of Osteopathy. He is considered one of the leading authorities on osteopathic practice and research, and he continues to disseminate worldwide on the subjects of back pain, clinical reasoning, evidence-based practice, and qualitative research, and the importance of developing these areas to ensure safe and high-quality osteopathic care for patients. Oliver provides evidence-informed online education and communication for musculoskeletal practitioners through www.wordsmatter-education.com. He's also the host of the Words Matter podcast, where he has critical discussions with leading academic clinicians across the MSK spectrum on topics related to person-centered care, clinical communication, evidence-based practice, and the biopsychosocial model. In the following discussion, we tackle a wide variety of topics related to patient-centered care, the importance of carefully selecting the words we use in clinical practice, and we touch on some of the questionable but common narratives that surround back pain. For more information and resources, visit us at www.thearmy.ca, and we hope you enjoyed today's episode.
My wife calls me Oliver. Ollie's absolutely fine.
Okay.
How do you feel about Dr. Oliver? The doctor?
Yeah, I hate it. Yeah, I sound like I should be. It's like Dr. Phil, on Oprah or something. I think I use it. I mean, obviously I use it on my social media, and I use it in formal academic situations, but no, certainly not amongst friends or podcasters or all that kind of stuff.
Yeah.
Yeah, so here in the UK, we don't. Our chiropractors have a kind of honorary title, doctor, and they can use it. They've got to make it clear that they're not medical doctors. That's the big concern for the regulator, that you go to your chiropractor thinking you're going to get heart surgery, but you just get some manual therapy. And in osteopathy, we never push for that. And there's a kind of section of the profession that wish we did have this honorary title, doctor. I would hate to have it. Even with the PhD, it's confusing. Patients are asking for opioids from me, and I'm like, I can't do it, man.
Yeah.
So no, I think it just confuses. Listen, the medics don't own the title, but historical events mean that they got there first in a way.
So we've got Oliver Thomson with us here today. Oliver is an osteopath and a professor out of the UK. If you wouldn't mind just kind of letting the audience know a little bit more about you, so they know who you are and who we're talking to today.
Sure, cool. So I'm Oliver Thomson, and I'm an osteopath in the UK, and I've been an osteopath in my 15th year, I think, or at least next year is my 15th year. And my time is kind of divided between an academic role as an associate professor at a reasonably large institution, or osteopathy institution in the UK, probably the biggest one, called the University College of Osteopathy. So I work in the research department there. They kind of keep me not locked away, but me and a group of colleagues, critically minded colleagues, in an office together. But saying that the institution, I'm fortunate I'm able to work for that institution because they pretty much allow us to publish and say what we think, which is great. So I'm there doing some research education, teaching research methods, mainly qualitative research is my kind of bag at the moment, and then publishing a little bit when I can. And the other side of my week, if you like, is in clinical practice. So I work in London, or northwest London, in a pretty unflash clinic. It's not some kind of hub of complex, centrally sensitized patients. They're pretty average people with pain and disability and want a bit of help. So I do that the other side of the week, and then, as with you guys, I just kind of started podcasting and dipping my toe into this whole field, which I've really enjoyed, and developed some online stuff, where education on language and communication, which is another kind of side passion of mine. And that's probably about it, I think.
Yeah, that's how we sort of found out about you, is through the podcast and listening to some of those really interesting episodes, and we'd highly advise people to listen to that. But what kind of inspired you to get that going and to get into that area or those topics on the podcast, and what are some of the long-term goals with that in the education service?
Okay. what inspired me, I think I was just a bit bored, not bored, but I just wanted something else. And I love academia, and I kind of really enjoy publishing. I love that kind of scholarly work, and I lead a PhD program at the UCO, which we're trying to get up and running in osteopathy. So I really enjoy all that side of things. But I like podcasts, like most people. I like listening to podcasts, and we've all got our kind of favorite podcasters, and I think I just felt I had a lot to say, or at least I wanted to speak to people that had a lot to say. Even, not necessarily me, but I just thought there were so many kind of wise people out there. And I've had lots of good conversations with some of the colleagues or some of the guests on the podcast, just at conferences and various places, and thought, wouldn't it be great if you could record that and share that information? So I just kind of pursued it and learned how to podcast, and went through various ways of doing it badly and doing it well, and reasonably happy with where we are at the moment. And the point is that the podcast is called Words Matter, and it was I guess originally focused. It's in its 15th. We just released episode 15, and it was originally focused on communication language. I perceived, you guys too, that our professions or musculoskeletal care is kind of replete with language which conjures up notions of damage and imperfections and all that kind of stuff, and which don't really map the reality to the evidence, and it doesn't seem to be very helpful with patients. So that was my personal frustration, and then took that on the road to a podcast. But it seems like the podcast is now might touch into some of the areas, other kind of issues within MSK care.
It really does have a good title with the words matter, because the words really do matter. And we've had a number of different guests on with us, various researchers, different clinicians, nutritionists, and that's actually a common topic that keeps coming up from everyone in all these fields. And you had a recent show with Dr. Rosatini, I think I said his name right?
Yeah, Giacomo Rosatini,
Yeah, and I thought that was a really good conversation, and something that we've talked about here before too is, yes, the words matter, and I feel like there's a lot of emphasis from some really good resources on social media on being positive, being empathetic, and really focusing on that aspect of our clinical interaction. Yeah. But what I find really interesting is maybe we should also be really focusing on what we shouldn't be saying, because that seems to be, if not equally as important, maybe more important, not to be offering these nocivic narratives, because heck, it's easy to slip out when you're talking to a patient and say something accidentally, right? So what are some of your thoughts on that?
I think you're completely right. And it's so I think it was probably born. So I think firstly, the title of the podcast and the kind of online learning stuff is purely by, I mean, it's not that inventive, is it? Words Matter. I think there are other podcasts called Words Matter actually, but it's really true. And I guess it's a bit, I don't know what the phrase is. It's kind of obvious, of course, words matter. But I think the challenge for us as clinicians is that, okay, well, once we acknowledge that they matter and we should begin to be very selective at how we use them, then some issues arise, because there is only a range of words that we can use, and we need to be quite creative about how we describe our experiences to patients and how we can reframe that. But much of our curriculum is kind of, just engrossed in the kind of language that we're kind of railing against or advocating against. So that's an interesting and it's a serious issue that we've got. We recognize language is really important, but yet we're still grappling with how are we going to explain this stuff to patients and how are we going to explain it to each other.
With the amount of experience that you have, do you still find yourself having days where, a patient walks out and you're just like, oh God, why'd I say that? Or is it getting easier with time?
It's definitely, I definitely have days. I mean, I definitely have days when I have no idea what I'm doing. That's the first thing. And there's often moments when I'm in the middle of some manual therapy technique and I just have a moment of, what actually am I doing? I think in terms of, yes, certainly I think I'm less militant as I was previously, where if words slip out, or if there are words which are used by patients which really carry meaning for them. And I think I spoke to one of the guys on the podcast that just bashing that word out of them and just kind of removing it, that's a kind of comfort blanket for them. And I think, so I'm much more kind of flexible. If patients want to just, use descriptors which I don't necessarily agree with, or I won't jump right in there and say, well, actually, you're wrong there. Discs don't slip, or the pelvis is, don't kind of fall apart. You shouldn't be saying that. I'm much rather than pulling them up like some kind of parent or school teacher, I'll maybe let it slide, kind of note it cognitively, and maybe move on, explore it at a later date. So I think I do let it slip, and I guess it's about, when do words matter? I guess there's an argument to say maybe they don't always matter. And for some patients, like, you can pretty much say whatever you want to them, and they're living happy life. They're psychologically kind of robust, and so I think even the idea that words always matter, perhaps they don't always matter, and it's going to be able to use that judgment. It comes back to this particular patient. In what way might the words matter? So it's a much more person-centered kind of judgment, rather than there are just words which we must never use in this kind of overarching kind of rule. So yeah, I'm not sure that really answers it, but I'm slightly less militant and more flexible.
Mm-hmm. Or kind of meeting the patient where they're at, and they don't have necessarily the same background in language. I had a patient in a few weeks ago who was dealing with chronic pain, and I was going through explaining the intricacies of pain neuroscience. Okay, not exactly right in that extent, but explaining how pain is this experience. And then I go through it, and does that make sense? She says, yeah, I have a degree in biopsychology, and this makes perfect sense. And I said, okay, well then how did I do? But afterwards she said, well, my back is out. So, but we just recognized that nothing is out. She said, well, I just don't, that's just the way I describe it. I understand that's not actually what's happening, but I don't know how else to describe what I'm feeling. So I said, okay, well, that's fine, because I understand that you say the words, but they don't have the meaning behind the actual literal definition of the words. So
yeah, that's the words that we choose have got to fit within some kind of meaningful framework, right, for them. And you're right, exploring some of those ideas or those existing beliefs before we all launch in and start correcting people. That's I think where my practice has changed. Rather than just pulling people up the minute they're speaking, I'll sit back a bit, explore that perspective first, and then see where that word sits or that phrase sits in the context of their narrative or perspective or whatever it might be.
So with that being said, and just talking about those clinical experiences, what maybe you could run us through first year of your clinical practice, a typical day or a typical session with a patient, and then what that might be like now. And hopefully that's not putting you on the spot.
That's a really good question. God, I can remember it, I think, certainly in the first few weeks. So I just said before that I often have no idea what I'm doing. I had the same feeling, my first week or first year of my practice, where I still didn't really know what was happening. I didn't know what I was doing. Like, obviously I knew my clinical methods were fine. I could take reflexes, myotomal examination. You could do that stuff. And so I think that first year or that first period of after graduating, it was really trying to understand, for example, back pain or neck pain, whatever it might be, in kind of anatomical terms. That was the perspective that I was approaching patients with. And I was just like, I've got, if I can just try and figure out the kind of biomechanical anatomical intricacies of this individual, then in relation to their symptoms, then I've cracked it. I've got it, right? I can just match up the treatment to that kind of theory, that biomechanical or whatever anatomical theory, and everything will be okay. Like, I'll just do it, and things will work out. And so that was most of my time was spent examining, trying to search for that, trying to make connections, and just look at how the subtalar joint moves and how that potentially might affect their left shoulder. And it's like, there's a plausible connection there. And so I just went through loads of rabbit holes, but then it just kind of turned out that it didn't matter. I can observe it didn't really matter what I did. Like, if I found those connections or not, patients responded in a variety of different ways. So it was most of it was just trying to focus on very intricate mechanics of the body, and trying to imagine imagining movement at certain segments and joints, as we all did. My communication skills were pretty. I actually worked in retail between high school and university. I worked in like a pretty high-end retail store in Knightsbridge. So you might know Harrods, right?
Yep.
It's Harrods. It's a store called Harvey Nichols, just down the road, equally ridiculously expensive. So my communication skills are quite good. I could deal with kind of difficult customers, people that wanted to spend, £7,000 on an ostrich purse or something. So I was quite good at that. I could kind of manage people's beliefs and behaviors, but so my communication skills were okay, but in terms of actually what I was communicating, it was probably horrible. I'm certain it was pointing at anatomical models and saying, this is your problem right here, and this is why, and showing how it moves. And so I think it was, I kind of blush as I think back, but it was pretty horrible, I think.
Yeah, I think we can all relate to that, because I mean, myself and Elliot are just over that 1 year hump, I guess 2 years, including our clinical internship. And Ben's still a student here too, so he's listening to all this saying, what am I not going to do? But just to move on to the second part of that question is, how would you say now, what's a typical patient interaction now?
So there's a typical patient interaction.
They'll be different for everyone, right? Of course.
Yeah,
but
of course. So I definitely so I still run long appointments, so reasonably long appointments compared to colleagues. New patients get an hour for me, follow-up patients 45 minutes. Most of my colleagues, and even colleagues at work in my clinic, they'll do half an hour appointments. And it's almost like it's an unsaid kind of transition. But the more experience you get, you can just cut your appointment time down, because you just become much more efficient and you can do these things. And I think there's some truth in that. You're not bumbling around with a kind of patella hammer, like what end is it? You can do things much, you're routinized, aren't you? You can do things much more cleanly. But I still need that time, or want that time, to really understand, at least as much as I can, that first session, just understand the person and have those conversations. I hate the feeling of being rushed. I hate the feeling of me rushing people and saying, right, quick, get up, let's have a quick look. I really don't like to be rushed if I was seeing a clinician, and I don't like the feeling of rushing someone. So I really like the time. I spend quite a bit of time talking to the first, 20 minutes or so, just obviously going through various kind of screening questions, trying to establish pathology or absence pathology, and just trying to get a handle on, what sort of pain syndrome or pain condition that we're dealing with. And through occasion, I use kind of screening tools like Start Back, but I use those kind of less frequently than I did. And really listening out to potentially, kind of psychosocial factors, which may be kind of relevant or salient to that person. And then, so I'm an osteopath, right? And osteopaths are obviously manual therapists. So there's a patient expectation that I'm going to do manual therapy to them. And I'm often aware of that, but I don't presume that. So what I often do now, which works really well, is just ask patients, what are you expecting from me today? And there's this presumption that which is not an unreasonable presumption, that if a patient attends a chiro or an osteo, that they're expecting manual therapy. That's not an unreasonable assumption, but nonetheless, it still remains an assumption. And so I think asking the patient, what is it that you're looking for today from me? What are you expecting? And I was surprised when I started doing that. Patients say a range of things. And I just want to understand a bit more about what's going on and what I can do to help myself. And then once I hear something like that, then I'm like, brilliant, no manual therapy. Or rather, I can begin to focus a session on something that's meaningful for them. If they say, I really want you to come in and put my pelvis back in place, then that's also important for me too. I want to know that, and I want to understand why they want that. And I might try and, there's some negotiation. You either say, that's ridiculous, get out of my clinic. That's just mad. You're mad. I'm not doing it. You could, and I've done that in the past, which is that's mental, that you're not having that done. Or you say, okay, that's really interesting. And you can talk around that and offer some alternative kind of ideas, and then maybe do something which kind of meets their need to have some attention to that area in a manual therapy sense. And, you kind of hold your nose a bit and say, oh, I'm going to do this stuff, because it's about building trust. And and building that rapport, building that confidence. So it's a kind of, and I don't know, it's a kind of it's a bit of a white lie for a longer term behavioral change or longer term kind of gain, I think. And I think that's ethical, because what's the alternative? The alternative is you just say, well, no, I'm not doing that, sorry. And it would be great if patients say, okay, that's fine. What would you like? What would you suggest? Some patients might say that, but many are like, yeah, well, that's really what I want, and I'll just go to the guy down the road that does it. He does it 10 times a month for me. And so you lose the patient. And so I'm a bit like my language, I'm much more flexible and say, okay, well, what does this person want? Let's try and meet in the middle, and then begin to explore those beliefs or perceptions around that desire, give them a little bit so they kind of feel that their expectations have been met, and then try and go somewhere else later on. That's a very long response, sorry.
No, I think that's like, I could not relate to that experience more. And that what you just kind of explained there is, I think, a conversation that we have in this group about 15 times a week about where's the line with if someone comes in and they want their SI joint put back in, and that's all they want. When you realize that, you take a broader look at what's going on in their life, and you realize that there's so many more factors contributing to their experience. But they know that SI's out. So where do you, right? Like, how do you find, and that's a really, really challenging area to navigate, because you think you know what they need, and they think they know what they need. And at the end of the day, it's the patient there, right?
Exactly. And I think saying to patients, it's equally wrong to say to patients, you need your SI joint put back in place. Have it. Here you go. Take it. It's equally wrong to say, you don't need that. What you need is some neuroscience education or whatever it might be. And I think to be person-centered, to give everyone the same thing regardless of their values is a very patient-centered way of practicing, right? So you've got, even if patients' expectations or preferences don't necessarily match up to ours or to the evidence, it's kind of incumbent upon us to still value those. And if it's not doing harm, like if in that short term, that first session or second session, if you kind of just fumble around with their SI joint, because really that's we're all fumbling. Even clinicians that think they're doing something to their SI joint, they're still just fumbling around blind, right? So there is that in itself isn't unethical, because everyone's fumbling around, and everyone's inaccurate, and no one's really doing what they think they're doing. So you can go through those actions. I think you can do the technique, and what you can do, which maybe the other clinicians don't do, is withhold on that necebic language. You might say, fine, you're saying you want your SIJ put back in place. You haven't got to kind of reflect that, but you can say, yes, let's explore that area, and there are some techniques that we can do just to, help, settle the pain or reduce that sensitivity. So whatever it might be, so you can kind of do the thing that they want, but kind of shape it slightly differently. And I think that's perfectly fine. I don't know. We haven't got many alternatives really. You either give it to them, or you don't give it to them, or you meet them in the middle.
Yeah, I that's exactly kind of where we end up. And so you touched on something just there that I think is personally a huge question for me. I think a huge question for a couple other people here is, and it applies to both professions of chiropractic and osteopathy and most MSK professions, I think. And it's that, at least in chiropractic, we have, and you talked with Dave Newell, we have this small subsection that is convinced of the idea that bones out of place will cause all disease.
Yeah,
and
this is a subluxation theory, right?
Yeah, and we like to honestly just kind of pretend they don't exist. That's a much easier world to occupy. Like, okay, those people will not change their mind. That's fine. That's how they exist. But on the other end, like the complete other end of the spectrum, we have this hyper-focused, hyper-biomechanical model that you've touched on today. Mm-hmm. And something that we've talked about, Dave and I, for sure, is that I think there's parallels between those two groups, because I don't think the language of either group leads to patient success.
Yeah.
Because, right? And so what I guess I'm asking really is, can it be equally as harmful in a hyper-biomedical, hyper-biomechanical model as someone saying that your bones out of place cause, your spine bone causes your foot bone disease?
Yeah, and so it's a good question. So I think, and I have a similar conversation with a friend of mine, and we kind of said, if you get two incorrect theories, what's worse? I mean, ultimately they're both wrong, right? I mean, if you're adopting a kind of super kind of spine orientated biomedically oriented or biomechanically focused position, and then something, I don't know how Dave described it, that the kind of the power of God is kind of being put through your L4. I mean, what that vitalistic perspective, both are incorrect, both are untrue. Which one's more harmful? I don't. Yeah, who knows? Who knows? But what I think where they're both going wrong, at least in my mind, is that both of them aren't what they have in common. Those two is my sense is that they're not placing the person at the center of the care. It's about something else, right? It's either about the mechanics or it's about, you know, God kind of permeating through L5. None of it's really about the individual, which is, you know, if you listen to the stuff with Matt Lowe, who articulates that really, really beautifully, that to me seems, you know, the most obvious position to adopt. And it's neither of those.
Yeah, I don't know if you were going to say something there, Dave, but that's kind of where we end up too, is it's just, there's a great quote that goes around that says that you can never be wrong, because once you realize you're wrong, you can change. So you're no longer in that wrong position. But I think people for a long time, and for whatever reason it is, just end up in that lane that they're comfortable occupying. And there's so much gray that we try to occupy that if you end up just in one specific lane, you're probably missing just a huge part, right?
Completely. And like where I think where the problem lies, or where part of the problem lies, is this idea of identity. And because both, if you look at the vitalistic guides, and if you look at the kind of, I guess we have analogous positions in osteopathy, most of these positions are really kind of hooked onto traditional conceptions of what it would be like, what it was like to be a chiropractor in, you know, the early 1900s, and what it was like to be an osteopath in the same time. And there's something that they hold these impressions so tightly, and we've got to stay close to these ideas because it has very clear distinctions with medicine, physical therapy, or osteopathy, whatever it is. And that's really important. And so those theories that we kind of cloak ourselves in to give us professional shape and kind of identity, that's like crucial. It's more important to us to be a certain way than to really help the individual. And by doing that, by cloaking themselves in these ideas or these traditions, you just kind of occlude good ideas, right? And evidence. And, you know, so I have this kind of utopic view that we just shed all of these stupid, you know, professional terms, osteo, chiro, and we just, I don't know what we are. We become just musculoskeletal therapists. I don't know, but it would never happen, right? Because for a range of kind of political reasons and professional reasons. But, you know, it's just, for me personally for me, and I'm not speaking for my institution or anyone else, the label or the philosophies or the theories tied to osteopathy are of no use to me whatsoever. Like, I discarded those. You know, I really can't see much use in them. And I think where they are helpful, it's purely by accident. Like, it's by accident that AT Still, who, you know, Palmer's kind of sidekick, may have talked about the person in like chapter 4 of one of his 25 books. And so, yeah, I just don't see it. But I also recognize that people have, just like patients, clinicians, practitioners also have values and preferences, and it's important for some people to feel like an osteopath or feel like a chiropractor. I just don't care, you know. I don't care. Well, I just want to help the person. Like, I really don't have anything invested. Like, you call me what you want.
Yeah, Dave, you want to go there?
Yeah, like, again, we have that conversation almost on a daily. Like, why can't we all just be musculoskeletal therapists or clinicians?
But you can't, because the reason why, and the reason why profession can't either, is because there's such a variance in views. You've got people, you know, and this is the challenge that, yeah, there is, as Dave said, there are middle grounds to our professions who are offering, you know, entirely ethical, reasonable, evidence-informed care for back pain, neck pain, shoulder pain, which is informed by the clinical guidelines and is really person-centered. That's probably where I don't know if it's the bulk of the professions, but a large part sit there. But you've got these fringes on either side or other sides, which would just never allow that change to happen, and it harms kind of progression, I would say.
Yeah, we see that every day on the social media forums, where we'll have some of these discussions, and in our profession specifically, it's always about spinal manipulation. Like, we're the best at it. No one else comes even close. This is what we are, and I feel like we're way more than that. And I feel it's the same thing for you as an osteopath.
Yeah.
Like you're way more than just those few manual therapy moves. But that leads me to.
So I was going to say, you guys, I feel sorry for you lot. We're all doomed. We're not all doomed, but my perception is, and that the adjustment, and I work with chiropractors, and I work with some very good chiropractors, but the adjustment is this, for many, is this intervention which just carries such power. Like, it's about the adjustment, whereas osteopathy have manipulation. We do quite a fair bit of it. We've got other techniques which are equally as ineffective. So we can hedge our bets through a range of interventions, a range of manual therapy interventions, and like say, we do a bit of manipulation, but there's some MET and massage, that kind of stuff. You guys are largely, it's about the adjustment, man. If you can just, you've got to come in and have bang, 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 4 or 5 adjustments, and obviously this isn't all of chiropractic. I'm not generalizing, but there's some perception that the adjustment has some intrinsic power or value that other kind of techniques just don't have, and that's sorry guys, I totally sympathize.
Yeah.
So one of my favorite papers that I think that I've read in the past year, it's a few years old now, but Neil O'Connell talks about it a lot, is the Joanna Fig-Latham paper from 2017, that quiet descent paper.
Okay.
And it's in osteopathy, but again, with my background and what I'm currently doing, I always relate this to chiropractic, because it's to presume that there's differences between the professions, and I think it's kind of silly. I think we occupy the same issues for the large part. But you touched on it, is that there's an apprehension, and there's this lens that we take. The professions are, I think, trending towards trying to be part of this the formal evidence base. We're moving away from that complementary term that Dave Newell doesn't like, right? That can. But yet we still have that lens that the professions move everything through. So we take, like Dave was saying, we take a study that uses spinal manipulation for chiropractors. Well, if a chiropractor wasn't the one in the study, it's not a good study anymore, because through that chiropractic lens, how could have that been an accurate representation?
It's different. The chiropractic adjustment is different to a physio or an osteo doing it. There's something unique about that particular intervention.
Right, and that's, again, I think we can probably safely agree that that's an absurd stance to take, that we are uniquely talented to move a joint slightly past its end range to make a noise. I don't think that's entirely true. But I guess I kind of want to ask about, through the lens of osteopathy or through the lens of chiropractic or anything, how challenging is it you on a research side of thing, and as an educator, to see well done science come out and well done evidence be created, and then just see it be warped through that lens? How do you deal with that? So
I think the prism of osteopathy, where you kind of see everything through osteopathy, it doesn't get you anywhere better than just the prism of evidence-based person-centered care. I just don't think it, because really the prism of osteopathy really just focuses on, it just says, rather than just looking at the biomechanics of the knee, look at the biomechanics of everything and all the kind of biological factors. Look at the diaphragm and the fascia. It just introduces much more kind of biological complexity, which so what? It doesn't get you anywhere closer to helping someone. So that's the irony is that when osteopaths kind of claim that their prism or their theories are much more holistic, if you like, and they kind of open up a range of different kind of pathways to help, and the identification of different factors which might contribute to someone's wellness or pain. Really what they're talking about is just lots more kind of biomedical factors. That's what they're saying, because the presumption lies that, well, physical therapists, and this is the old argument, physios, physical therapists, they really just look at just if you've got knee pain, they just look at the knee, don't they? Whereas we look at the hip, we look at the foot, we look at this. So they just take a much more kind of biomechanically holistic view. In terms of, that wasn't really what you're asking. In terms of, what was the question?
No, that's actually like another part of that question, right? I think holistic is a hilarious term, right? You have knee pain. It's actually your ankle dorsiflexion. Yeah, sure. That might actually contribute in terms of how loads shift. But like, again, do you know if that person's had limited ankle dorsiflexion for 30 years or not? You don't. Right?
Exactly. And I think, if you look at the CFT, guys and girls, Sullivan and vice versa, all that kind of crew, to me, in terms of kind of holistic and musculoskeletal care, to me, that's it. Like, it really does encompass a load of kind of evidence-based factors and interventions and frameworks, which I think is far more sophisticated and usable than the osteopathic theories and chiropractic theories. I mean, even before we get to the kind of plausibility or the of some of these frameworks that we have in our professions, they're not even usable. Do you know what I mean? Like, you know, lots of them are kind of just, they're in old books, and you're trying to read the words of someone from, you know, 1900 about their impressions about the world and relate that to current practice, and it's just not, it's not helpful. So no, I still haven't answered your question. Sorry.
No, again, that's still fine, because my question actually wasn't that good. But it kind of does tie into something that I know Dave wants to talk about, and it is a bit of a shift. But what I'm getting at here is, so we view kind of the evidence how we want to view it, right? That's our inherent bias, and everyone will do that. But what happens sometimes is some loud voices will propel those concepts, right? Those misinterpretations like that are seen in the literature, because we're not all perfect analysts of research papers. We can read a new study and not fully get quite what the authors were hoping at.
Yeah.
But then people can be loud and be very vocal on social media. And I know we always say that social media is a death trap, but it's kind of a forced reality now. But I think what we want to know, and just your opinion on, is, do you think it's an epistemic responsibility of practitioners to call out some of those discussions on social media? Or do you think it's not worth the time, knowing that people probably won't change?
Oh God. I mean, like, you know, I don't know. It's really hard, because part of me thinks, you know, where did I see this quote? What is it? Flashed up on my Instagram. That, you know, we have a duty. I mean, listen, if you look at the call to action paper by Bookbinder in the Lancet about back pain, right? And they had a series of kind of points at the end, and they said something like, you know, that along the lines of we should kind of call out. I mean, they didn't say that, the word call out, but we should really kind of address practitioners who are using kind of dated or ineffective kind of treatment or kind of management frameworks. So I think there is. I think if someone that's in a position of academia and, you know, producing some of the research and having some kind of leadership role, possibly in the profession, I kind of see it as a duty to correct some of that misthinking or misspeaking, but I can't say that it ever works. Like, it's because it can't go unchallenged. That's the thing. That if you're going to just put, you know, nonsense on social media, I just can't. There's a part of me I just can't resist. Like, you know, at least trying to, you know, and maybe not calling out. And I try, you know, I'm not good at it. I was doing it yesterday, and it just didn't. I don't know. I try and be as soft and as gentle and as understanding as I can, but it doesn't always work. So I haven't really got a good answer. Like, I feel that it needs to be done, but I think it's entirely ineffective when it is done. You know, but I don't know what else to do.
Yeah, I think that I know that the Physio Matters podcast did a little tweet thread a few weeks ago that talked about just this, and said that, you know, part of the responsibility is not just trying to call people out, because they might not change, but people are watching. Right? If you don't want to look at social media metrics, but if you put out, for example, a tweet that lots of people resonate with, you might only get, let's say, a handful of retweets and likes. But if you look at those analytics, like 3,000, 4,000 people have interacted with that, right?
For sure. I mean, I've got, on my Facebook, you get adverts or video adverts for clinics and interventions, and you just look at the views. I mean, these are hundreds of thousands of people watching some guy with a hammer smash another guy on the shoulder wearing kind of black plastic gloves. And I mean, that makes, it just makes my blood boil, because it's everything that's wrong with everything, right? Everything's wrong with healthcare. Everything's wrong with social media. And you see the comment, and you read the comments, and people are kind of falling over themselves to just praise this individual who's just, manipulating or bashing or doing the kind of traction thing. And you see it when people have posture, the adverts for the posture shirts, where these shirts are going to keep your posture up, and you see the comments, and it really does spread. So yeah, I mean, it's what gets me super frustrated. You've got papers that come out, it feels like it's just against a tidal wave, when you've got people that can produce a video of someone having a load of kind of adjustments or kind of theraguns or being bashed, and they just get hundreds, if not millions, of views, and there's us three doing a little podcast. I know that Peter Sullivan and Mary Keefe have written stuff around this, around social media, and trying to address it. But I don't know how we all unite, because it seems like we're all just doing these little battles together on social media. It just doesn't seem to work. I don't know.
So we've talked about all these things because I think it's safe to say that when you occupy this space and you're having these conversations, it's inevitable that there's just endless frustrations. Like you said, it's bashing your head against a tidal wave. It feels insurmountable some days for sure, right?
Yeah.
In your role as both an academic and a clinician, I think you occupy that niche that people really admire, because I know it's unfortunately common that clinicians will say, well, academics aren't clinicians.
Yeah.
But you have the opportunity to occupy both situations, which I think is fantastic. From your perspective, has that led to any kind of different interpretation, or do you think there's still the same issues?
I think partly from the kind of the words matter kind of online stuff. I think that came from me as a clinician and as an academic saying, actually, there is a better way, like, you know, and so you kind of think some of the nonsense that's around on social media, or some of the terrible practices that we see, are purely innocent, right? People don't know other ways to practice. And I was taught this at uni, and I don't know how else to practice. Show me another way, you know, and I'm happy, I'll be open to that. And I think we have, you know, an opportunity to change some of those practices. But and that's great when that does happen, when I have, you know, people messaging me saying, loved your podcast, or, you know, did the course, really, really liked it, really found it useful. That really does make me feel good, and that it was all worth doing. I think some of the stuff that we see, which makes our blood boil, is more so playing on the fact that I'm not a mind reader, but my sense is that they know that it's sensationalized. Like, they know that, you know, the whole setup, isn't it? It's just totally sensational, social media orientated, lots of clicks and cracks, and the kind of influencer type thing, you know. And it's like, it's all about how it looks, and there isn't really and I think what at its core, there isn't a genuine concern for the person. Like, this isn't about, this video that I'm doing about clicking and adjusting, I really want to help people. It's more about likes and views, and it's totally the antithesis of what healthcare should be about, you know?
So, and this was a discussion that you and Dave had a little bit, but we see all of these like fancy technique courses and students rushing out to go and do them. I made the big mistake of signing up for one like half a year ago, and greatly regretted the whole experience of it. It was just something that was suggested to me by other mentors. And the students that I see there are just so like into it, and like, this is the new technique, this is what I'm going to use all the time, and this is amazing. How have we gotten to this point where a student can come out in their first year in practice and all of a sudden jump from one technique to the next? My thought, and I want to hear yours, is that we haven't been exposed in school to enough stories of failure. I think we're hearing all of these success stories from the tutors and professors talking about how we're going to change lives, and that's just not the reality. You said it earlier in the podcast that you can look at it a bunch of different ways, and a certain patient will respond great, somewhere in the middle, maybe not so good, and along that spectrum, right? So is that because of how things have been presented to these new clinicians, or because we just don't know enough and aren't expected to, or taught to expect, very equivocal or less positive results in the clinic?
Yeah, I think there's a few things. I think there's something around not being comfortable with uncertainty, right? And not being comfortable, or not preparing students for that clinical uncertainty, to recognize that there really aren't, you know, there aren't black or white, very rarely black or white situations in clinic. It's just shades of gray throughout. That's the first thing. And I think where we fail as educators is that, yeah, perhaps we don't develop students' skills in reasoning and kind of managing uncertainty. And so therefore they are drawn towards theories and courses, as you said, around technique, which give very simple explanations, aren't they? These are simple explanations for complex problems. And as well as looking kind of flashy and, you know, highly skilled. I think that's the first thing. I think, and I think that, yeah, and it perhaps it's on our part, a lack of a coherent, kind of cogent theory of practice. So I think a failure on our part is that we haven't adequately disseminated or convinced education institutions that there are alternative, and what Dave was saying in the podcast, explanatory frameworks and clinical frameworks, which both meet the desire for clinicians to have some kind of professional value and some identity, but also are informed by evidence and hopefully more efficacious than the traditional theories. We haven't just done a good enough job. So I think it's something around that. It's that students are, and also probably a lack of mentorship, certainly in the UK, and certainly within osteopathy in the UK, we don't have clear kind of frameworks for clinical mentorship. So you do your 4 years here, you're supervised for your last 2 years in clinic, and you can go off and you can go and charge $1,000 a session or $100 a session, and you can pretty much describe yourself in any way that you want in terms of expertise. That you never really, the continued professional development, the CPD program has changed here, where there is some mentorship and some peer observation. But up until recently, it was just like you just go off into a little corner in some little village somewhere and just do what you want, and no one really. As long as you submit 30 hours of kind of CPD each year, no one really kind of expects you to change or the desire to change. So. Yeah, I think I said in that podcast with Dave that, I've had examples of students who just I see a year later and they're super critical and informed and energetic, and they're just enrolling on some bizarre course. And yeah, I think it's about people exploring these things. I think the original reason why people came to do osteo or chiro, as Dave and I were saying, was that there's a tendency, or what's the word, a disposition to be kind of wanting to find out about the fringes of knowledge, the slightly alternative theories, and maybe they just carry that through. I think there are financial implications too. Like if you can say that you can treat children or babies here, like it's a cranial osteopathy when you can hold in the heads of little ones and thinking about what you're having for breakfast, or thinking about the bones moving and all that kind of stuff. It's pretty popular here, and you can make a fair bit of money. And I have no doubt that many of the clinicians doing it genuinely believe they're helping people, helping children. But nonetheless, it's about skilling up and increasing your scope of practice. And so, yeah, there isn't a clear answer, but it's a shame.
Yeah, I think you touched on a lot of great stuff there. And what we find is as you're talking about, like, a lot of people take those, like, as an individual course and they're latched onto that protocol. The big thing, at least that we see in terms of mentors who are this evidence-based approach in the chiropractic profession, for us, that'll be watching a practitioner do acupuncture for 20 minutes, some soft tissue work, and then hand out a rehab slip as they leave. And that's what we look at as being forward thinking or evidence-based. That's what's happening for us, at least right now in Ontario and Canada specifically, from what we see. And it's a little disheartening. And so I'm gonna. Oh, sorry. Go ahead. If you guys wanted to say that.
Yeah, I was just going to say that I think where we find ourselves in a bit of a tricky situation as osteopaths and chiropractors, that the two professions are really built on two things. They're built on anatomy. Really, it was really about anatomy and an interpretation of anatomy and the implications of anatomy for health and well-being, and then specific techniques which can map to that anatomy. They were. There were the two core things. I'm sure some chiropractic historian will argue against that, but largely, from my perspective, it was about technique and anatomy. Right, that was it. And you can apply your technique to affect the anatomy or physiology. It now turns out, it might just be bad luck. It now turns out that both anatomy and the specificity of manual therapy just aren't there in terms of predicting outcomes or predicting outcomes or development of these things. And yet we really put all our eggs in these two baskets. Like, right, this is it. We kind of took that space, and it turns out that it was just not the right horse to back, if you like. And so now we're like, oh God, what do we do? And so, and you kind of like, well, and so people hold tightly onto these things, but then I just don't see the problem with just moving and shifting. So, okay, well, like we've all had to do. We get that it was thought that anatomy was a really big deal and structure was a really big deal back in the day. It turns out that it's not. Doesn't mean it's irrelevant. we just got to now place the importance that it deserves in relation to the evidence and anatomy, and the same with technique, and just skill up and incorporate some other interventions. This is why I'm always slightly puzzled. Like, so what? Like, just do what? Like, what's the big deal, man? Like, just if an intervention is less effective, or if there are better interventions to perform on or to deliver to patients, and you're not doing it, that's an unethical position to hold. Like, and if you're not doing it for reasons because you don't think it fits with your own professional conception, that's even a worse reason not to do it. So yeah, I don't, I sometimes I fluctuate between a real hard liner, like, why aren't you doing this? And then much more gentle, everyone's got their own time. But sometimes you think it's not, the whole biopsychosocial model, it's not new. Like the conversation you and I are having now, you would have been in a cave for the last 20 years not to encounter these views. And so when people aren't changing, I'm thinking, well, why aren't you changing? Like, I get that many clinicians just won't know how to change, but I think there are some much more reasons which are much more based on self-interest actually than anything else.
So on that point, something that I probably didn't ever see happening to me, we've been called you pain science zealots or extremists or whatever with some of the comments that we've made, in saying, like, why can't we just take a little bit more time to be more empathetic and talk and listen to our patients? Yeah. And I've heard you have this discussion before with some others. I think they think we're saying you need to just ditch all the manual therapy and start talking and start getting your patients to do exercise, and that's it. And that's not at all what we're saying. There's always room for some of these other therapies. So you've talked about your journey of like integrating, just going right in with that first patient on a Monday morning, and how that maybe didn't work, just applying the pain education. So if you had any advice to other clinicians on how to slowly progress, or what it means to slowly incorporate sort of like that an active biopsychosocial approach to your practice.
Yeah, sure. So I'm going to kind of recommend that listeners listen to. So I spoke with a colleague of mine, a chap called Jerry Draper-Roddy, who's just got his doctorate a few years ago, and we did a podcast, had a talk specifically about his transition. And it could have been my transition, any transition, but he was just someone who was really good to speak to about his transition from someone that was kind of European osteopathy, which is quite kind of biomedically orientated, and kind of is now shifted, finishing his doctorate, essentially the biopsychosocial model, and now doing research, primary work into the field. And he articulates that really well and provides some guidance. And so I think, I think what you said, that what often people hear, and again, it might just be errors on our part and not communicating our position clearly enough. And probably if I listen back to what we've just talked about the last hour, it probably does sound like I'm advocating for just completely binning any kind of physical manual therapy interventions, which I'm really not. Like there's definitely a place for hands-on. Manual therapy is about creating experiences, and we are in the business of creating experiences with patients. And in our case, it's with our hands, and we can reassure, we can expose patients to movements and all that kind of stuff. So the manual skills certainly have a role to play, and I'm not arguing that we bin them at all. It's just we've got to be realistic about the role that they do play, and they are just a range of tools that are at our disposal. Many clinicians will say, yes, I know that. I do much more than manual therapy. But when you look at some of the evidence around clinicians' practice, it still is manual focus. They might, the skills around the biopsychosocial model or communication are still quite lacking. So I think it's about being honest about, okay, where really are we quite weak as professions? And I think in terms of just tips for people to kind of what they're interested in, kind of transition their practice, I think just get over the fear of kind of doing it wrong. I think it's good to make mistakes, and we all make mistakes, and I'm still making mistakes. You can't really get that much wrong in our line unless you miss a pathology. I think there are gradations of wrongness, right? I mean, if you miss pathology and you start, holding on to patients that really have some multiple myeloma, that's a problem. But aside from that kind of clinical screening, the natural course of something like back pain is pretty good. So you're not going to beat yourself up too much. And I think just begin to follow people on social media that you want to learn from, and unfollow ones that you don't. And listen to podcasts like ours, and then begin to pick, you really think about the sorts of courses you're going on, and if they're just, developing skills which are probably already entirely adequate, such as manual therapy, why do them? We should start to do skill up in areas we're just not very good at.
Yeah, I think that's the nicest kind of ending summary we could have had. So Ollie, thank you so much for taking the time to speak with us today. Now is your time where you can advertise for every single thing that every person should purchase or listen to from you or follow you. So if you could give your full rundown of courses, of where to find you on social media, we would love to have that at the end, and also Dave will put it at the beginning too.
Brilliant. So you can find me on social media. I spend too much time on it on Facebook, and which is, I think, Dr. Oliver Thomson, osteopath PhD, and then I'm on social media on Instagram, which again I think it's Dr._Oliver T. And Twitter something similar. It's not, they're all some combination of those letters. I think really where I'd like people to go is listen to the podcast. They're totally, and they're not good because I've just been lucky to get some really good guests, and I'm fortunate that people that know far more about this stuff than I have given up their time. So listen to the Words Matter podcast on all the platforms, iTunes. And then if you want to learn a bit more, like I said, I run a little online course, which is pretty cheap. It's like 50 quid, which is, I don't know what that is in Canadian dollars, $80,
like
$90?
$80, yeah.
And it's like 3 hours of me just kind of going on about some of this stuff. And it's supposed to, and students get like half price. It's not for me to make any money, but just a way to kind of vent my or disseminate my information, my knowledge. And that's at words-matters.com, which Dave will put in the show notes.
Yeah, absolutely will. Yes. Thank you so much. This was fantastic. This is we love having the opportunity to share an echo chamber and expand that echo chamber just even more, because if there's one thing we all love, it's just to hear things that confirm our biases, right?
Hey man, that's what we're all here for.
Thank you so much.
Bye bye.
Take care.